Okay, well, hello, everybody. My name is Eric Hollander, and I'm a professor of psychiatry at Albert Einstein College of Medicine and director of the Spectrum Neuroscience and Treatment Institute and Foundation in New York City. We have a series of conversations with leaders in the field of neuroscience and mental health and its impact on the media as well. And we have a special guest today, Samuel J. Mann, who is a professor of clinical medicine and a specialist at the Hypertension Center at the New York Presbyterian Hospital and Weill Cornell Medical Center. And he is the author of a new book that's come out in the past year called Hidden Within Us, A Radical New Understanding of the Mind-Body Connection. So, Sam, it's great to have you here today. Tell me a little bit about your book and this mind-body connection and what's sort of new and unique about your understanding of this topic.
Thank you, Eric. The book is about a very different understanding of the mind-body connection. And there have been many books and a half century of research about the mind-body connection, and everybody's aware of that work. But I'm speaking from my specialty of hypertension, but what I'm going to say is relevant to many other prevalent medical conditions where to this day we do not know the cause. And a proportion of those patients, I believe it is mind-body, but different from what most people think. I'm talking about chronic fatigue syndrome, migraine, inflammatory bowel disease, chronic pain disorders, autoimmune diseases. All of those, in most patients, we don't know the cause. And what got me interested in it is in my field of hypertension, a lot of attention has been given to the mind-body connection. And interestingly, after a half century of research, it has led nowhere. They have not been able to prove that stress and emotional distress cause hypertension, or that relaxation techniques or other such biofeedback meditation are effective in relieving it. And what they did show is that, yes, in the moment, stress or emotional distress raises our blood pressure, and then it comes down. And that's normal physiology. In fact, normal physiology is when you lift weights, your pressure can go up to 220. Nobody gets a stroke from lifting weights. But the key question is, well, what about persisting hypertension and all these other conditions that we don't understand? And what the mind-body research has led to is very little in terms of gaining understanding. The book is a new frontier in medicine, and it's about the emotions we are unaware of, emotions that we have repressed. We're unaware of those emotions, and they are affecting us. And we have no idea that those emotions persist within us and affect us because we don't feel them. And I learned from my patients, and it's been a fascinating journey.
Okay, well, let me jump in with a couple of initial comments. So, first, in terms of, mental health issues, we really don't know the cause of many different kinds of mental health conditions. And I guess if you have a clear-cut cause, then these different conditions leave, let's say, the DSM-5 diagnostic manual. And if you have a known cause like Fragile X syndrome or Prader-Willi syndrome, then it's not a mental health issue. One thing I think that's unique about hypertension is you have a good biomarker, right? You have a quantitative measure of blood pressure, and therefore you can take a look at the relationship between all kinds of different things and this particular kind of biomarker. What do you want to say about that?
I would say exactly that. It is a very convenient biomarker. I'll say more recent research is more reliable because previous blood pressure measured in the moment, and we all know this, a lot of patients come into the doctor and their pressure is elevated because they're worried, what's my pressure? Since we've started doing home blood pressure monitoring and 24-hour blood pressure monitoring, that eliminates that problem. So we do have the blood pressure as a physiologic marker, And that is one reason why so many people have sought to research this and in looking at the mind-body connection.
Right. So what makes you say that, emotional states or trauma, for example, have a profound impact on hypertension?
Okay, first thing I would say is, in talking about mind-body, 80 to 90% of hypertension is not mind-body. It's genetics, it's weight, it's salt, it's lack of exercise, all those factors. And it's mainly driven by the kidneys, and the medicines we use target the kidneys. Where I think hypertension is a mind-body disorder is where it's driven by the sympathetic nervous system. And different medications work for that. But it's amazing to this day, if you ask any hypertension researcher what underlies the increase in sympathetic nervous system tone that causes hypertension in that fraction, they will say they don't know. And they've done all kinds of research with the emotions we feel. They've gotten nowhere. Breakthrough that I got was listening to patients who had uncommon kinds of hypertension and hearing their stories. So, for example, a patient who was getting severe, sudden bouts of severe blood pressure elevation, lasting for hours, very high blood pressure, often emergency room visits, and nobody knows what causes it. And they get these again and again and again for months and years. Nobody knows the cause. And what struck my interest was some of those patients talked about a childhood history of abuse, physical abuse, sexual abuse, but they insisted no, it had nothing to do with it because that didn't affect them. And I think the patient that pushed me in this direction the most dramatically is a 60-year-old man with episode after episode. Nobody could explain, nobody knew how to prevent it. And he had no stress, marriage, family, money, everything was good. He was a Holocaust survivor. And when I asked him, gee, I wonder, this is a blood pressure going up suddenly, a sympathetic nervous system, could it be related to that trauma? And he said, no, it was decades ago, and it never affected me emotionally. And that was an aha moment, that to experience that and be able to say it never affected me, that is repression. And it's not like we consciously decide to suppress the emotions.
Right.
He's not even trying. It's
Uh-huh.
repressed at an unconscious level. And he would swear there's no emotion there and would have no idea that emotion persists for decades within us, even though we are not consciously aware of them.
Uh-huh. So, I guess many people who have had early kind of trauma, and let's say a child who was a victim of a Holocaust or was in a concentration or camp early on. So that's a horrific, really early trauma. But many of the people who have gone on to do well have utilized repression, in order to be successful, in order to not dwell on these sort of early traumatic memories and sort of refocus and be successful in other ways. So what makes you think that there's an ongoing connection, I guess, between this early trauma and this sort of physiologic response?
A couple of things, both in hypertension and in other conditions. The studies show that the number of adverse childhood events is higher in patients who have these conditions versus patients who don't. So there is a statistical association. The adverse childhood, the ACEs questionnaire, is not the perfect questionnaire, but it is an objective measurement, and it is connected. The second thing is, I have patients who get in touch with those emotions and the condition disappears rapidly. I've seen this with migraine. I've seen this with certain patients with hypertension.
Uh-huh.
And it's possible in others. And, it raises the question that if these are such horrific trauma in the past, is it possible to get in touch with those emotions? Is it safe to get in touch with those emotions? And that's a very important question. And in some people, it is not. And it was not meant to be uncovered. Repression is not psychopathology. Repression is a gift. Evolution had to give us the ability to repress. And it's something to be respected. And when I talk with patients, I see where it's going. I do not force a patient, oh, you must get in touch. I see how the patient reacts, and accept that I cannot judge. The patient has to be the one in charge of that.
Uh-huh. So to some extent, I guess you follow the patient in terms of the timing and when they're able to deal with that. Now, there's been a lot of interest recently in other approaches to help people deal with sort of traumatic memories and sort of be able to have the memories come out, but manage some of the strong emotions associated with it. So, for example, in psychedelic psychotherapy with things like MDMA, ecstasy, or psilocybin, for example, uh, patients often are encouraged to get in touch with earlier traumatic memories, but in a safe or a holding environment, so that the memory can be reconsolidated, but without all of the powerful negative emotions that were originally associated with that memory. What are your thoughts about those kind of approaches?
I think it is fascinating. I think we do not have the data to know whether it is safe in all patients or some patients, or how to tell. There is no data. And I also have to keep in mind, these patients did not come to me to deal with past trauma. They came to me to control their blood pressure. And I cannot assume it is safe for them. And that is a concern. And I think that needs to be further examined. How do we tell, is it safe, especially in patients who are not aware of the emotion and we're not coming to dig it up?
Right. Now, I guess in, certain conditions like post-traumatic stress disorder or even panic disorder, I guess it's understood that there can be sympathetic surges, pouring out of norepinephrine or adrenaline, associated with panic attacks or sort of traumatic sort of re-experiencing in PTSD, for example. What do you think is different about people who manifest with this sort of hypertensive type crises and those, I guess, who don't, or those who manifest the early trauma in other ways, like PTSD or panic disorder?
Right. I want to say two things. One, the patients that I see, I mean, military service and trauma and PTSD, they say 29% get PTSD. What fascinates me more are the 71% who don't get PTSD.
Uh-huh.
And these are the patients who didn't get PTSD. I think in this form of blood pressure surges, I think it's a cousin of panic disorder. And in panic disorder, you get that much emotion and this much blood pressure elevation. And in paroxysmal hypertension, these episodes, it's all the blood pressure. It's not panic. They're frightened because of how sick they feel in the moment.
Right.
But again, the emotions are nowhere near as close to awareness.
Right.
Another thing I want to stress, it's not just the episodic hypertension that's driven by sympathetic nervous system and by repressed emotion. It's also in a significant proportion of patients with severe unexplained hypertension. And nobody can explain why they have such tough hypertension.
Uh-huh.
Many of them have stories with repression. Also, young people, a thin 25-year-old should not have hypertension. We always look for a medical cause, and we find it in about 10 or 20%. The other 80%, why do these young people have hypertension? Almost all of them have a story.
Right. I think that we're familiar with the idea of white coat syndrome, right? There are some people who, when they go in to see the doctor, their blood pressure goes up, I guess because they're they're anticipating or they're focusing on their body, for example, and having some level of anxiety associated with that anticipation. Are we talking about the same issue, white coat syndrome, and what you're describing, or is it different in some way?
Very, very different. The white coat hypertension, usually the patient is very anxious about the blood pressure, and it's a temporary elevation in blood pressure, usually without symptoms other than anxiety. They don't have a headache, and it's not uncommon. 10 to 20% of people have a higher pressure when they see the doctor. Part of the problem also is that the doctors don't have the patient sit for a few minutes, but that's another story. But
Uh-huh.
there is very palpable anxiety occasionally in a patient who doesn't even feel the anxiety, but it's transient blood pressure elevation, more in line with labile hypertension, labile elevation of blood pressure. And with anxiety, yes, pressure goes up and it comes down. It's not hypertension, though. It's in the moment.
Uh-huh. No, I think one of the things that you said that was fascinating to me is that the patients that you see are the ones who have successful repression, right? Whereas the patients who might come into an anxiety disorder program are those individuals where the repression is less successful.
Yes, the patients I see, it's not like they're living with anger, which is a result of conditions from childhood. These are patients who truly are free of emotional symptoms. And again, with severe stress that people go through, what a gift repression is. And when I talk to patients, I explain that to them because, first of all, they weren't expecting a mind-body explanation. Second of all, people don't like to hear it's mind-body because, oh, you're telling me I'm crazy? And number three, I emphasize repression is not psychopathology. Evolution had to give us the ability to repress. Otherwise, even more people in this world would be in trouble. And I tell them, your mind did exactly what it needed to do at that time. And
Uh,
if their life is in order now, there might be a chance to deal with it, but their mind did exactly what it needed to do. And I've had patients tell me, well, I'm glad to hear that because the other doctor was telling me it was in my head.
uh-huh. Another thing that you said that rang a bell for me is, so I guess you have these different kinds of emotions, which may or may not be repressed. So one emotion is is anxiety. Another emotion is anger. So tell me about the differences between anxiety and anger and how there may be differences in terms of blood pressure effect.
It's a little less clear when you talk about the emotions, anger and anxiety that we are in touch with. You're talking stimulation of the sympathetic nervous system, and anxiety stimulates more the epinephrine, the adrenaline increase, and it's manifest with a rapid heart rate and the heart's pumping away. Anger is both epinephrine and norepinephrine, the two limbs of the sympathetic nervous system, and you get more vasoconstriction and less increase in heart rate. So anxiety is often associated with the rapid heart rate. That's where the emotions differ in their physiologic responses. Another point is when we're talking about emotions that are repressed, yes, in some it's anxiety, in some it's anger. The other important element is what is the severity of the emotion? What was the severity of the trauma? So yes, is it anger? Is it anxiety? And how severe it was? And the more severe the story, the more careful I tend to be about exploring. And I feed a hint and see where it goes.
Uh-huh. I think that we're familiar with the idea, the psychoanalytic idea that, people who have, let's say, angina or chest pain can sometimes be experiencing like anger that they may not be aware of, right? And that anger may be expressed in angina, for example. What are your thoughts about that?
I think that's less clear. I mean, I typically think of angina, chest pain, either it's usually from coronary disease, or it's some other problem in the chest. And that's the main question. Where there'd be a relationship with anger, whether it's conscious or unconscious, the physiologic strain, if you are angry and if it's repressed anger, you won't even be aware of it. It can stimulate the sympathetic nervous system. And if you have a narrowed coronary artery, you'll get chest pain. So it's not the cause of the coronary disease. Actually, it can be for other reasons, but it's the manifestation, symptoms that derive from the combination of coronary narrowing and the physiologic stress of severe emotion.
Uh-huh. Okay. Now you've kind of started out by drawing a broad net with this mind-body connection, and that there's a similar process going on with these sort of labile episodic hypertension, I guess, or resistant hypertension, and then other conditions where there's no known cause, like chronic fatigue syndrome or autoimmune illness or irritable bowel syndrome. So is it the same sympathetic activity that may be involved in those other conditions, or it's the impact of early trauma that activates other systems that manifest those different kinds of physical symptoms?
I think it could be many things. Studies consistently showed increased sympathetic tone in chronic fatigue syndrome, in autoimmune diseases. So it does involve that. There could be other, where cortisol fits in, I don't know. There could be other pathways. The other thing is you have the autonomic nervous system has two limbs, the sympathetic nervous system and the parasympathetic nervous system. Parasympathetic nervous system is vagal tone, and those are reciprocal to each other. When you have increased sympathetic nervous system activity, the parasympathetic, the vagal, is decreased. And a decreased parasympathetic and increased sympathetic is associated with increased inflammatory markers. You have all these inflammatory diseases where you have increased inflammatory markers. We know that. Nobody knows what causes it, but you have this imbalance of the sympathetic and the parasympathetic, and they actually have procedures where they stimulate parasympathetic tone, vagal tone, and the inflammation gets better.
Right. And nowadays, we're all worried about viral triggers. We're living in the age of COVID, and people develop all kinds of symptoms after having COVID sometimes. So manifestations of long COVID, and then other unexplained illness, whether it's, chronic brain fog, for example, or postural orthostasis, for example, where people can, get dizzy or have an increase in heart rate, when they stand up. So what do you think about different types of the role of viral triggers and how this may interact with some of these conditions?
That's an interesting question. I could talk for a half hour, but if you ask our colleagues in infectious diseases, they will tell you flat out, chronic fatigue syndrome is not an infectious disease. Maybe here and there is a case, but every few years there's a new fad diagnosis. First it was chronic mono, then it was chronic Lyme. Is it real or not? It might be real in some patients, but in others, perhaps a majority, it isn't. Now you have chronic COVID, and I wouldn't be comfortable guesstimating what proportion of chronic COVID is from the COVID infection versus related to, for example, repressed emotions. But I think that in many, it is part of it, and it needs to be further explored. And sometimes it's hard to know.
Uh-huh. What about the timing of the trauma? So you seem to focus on sort of early childhood trauma as being a particular risk factor, I guess, for the development of some of these conditions. So is there something unique about the effects of trauma on the body when somebody's in an earlier developmental, let's say, stage as opposed to later on in life?
That's an important question, and I did not mean to exclude adulthood trauma. I think adulthood trauma absolutely can cause all these things. I think that during childhood, it has a bigger impact because we have less ways of protecting ourselves emotionally.
Uh-huh.
And as an adult with some more maturity in some of us, that we can handle it better. But I'll give you an example. And, when we use the word trauma, I would also say severe stress or prolonged stress. So, for example, I've seen patients who were immigrants, and we don't know the kind of lives they live when they first come here. They don't speak the language. They don't have money. They don't know what they're going to do. They work 16 hours a day, 7 days a week for 20 years, and they're okay emotionally. But I've seen hypertensive problems related to that, and I've had patients get in touch with that emotion and it got better. But I think prolonged stress, even not reaching the level of trauma, prolonged stress is an enormous physiologic stress that cumulatively also needs repression. And some people repress very well, and it's a blessing.
Right. That, raises two thoughts on my part. One is the immigrant experience. You see many people who come from other countries who really are strivers, right? So they work hard for success and they overcome odds and they have resilience, I guess, right? And then I would say that there may be other individuals who may have experienced some kind of early adverse event and then experience some kind of stressful event later in their life that sort of brings this on. So what are your ideas about why some individuals are more resilient, and then how like subsequent trauma may trigger this effect in individuals who have had earlier trauma?
That's a very interesting question. And I've seen patients, I mean, just the fact that somebody has had trauma and they've been fine for 25 years and now they have this problem, even in the absence of a current stress, does repression wane or fail over time as we age? And I think that's part of the problem. And maybe in the presence of acute stress, it brings it on more rapidly or more apparently. It's interesting. I see patients, we think of anxiety disorders as generalized anxiety disorder for a lifetime or situational anxiety. I see patients who never had anxiety and they come and their pressure's up and they're very, very anxious and life is fine. And you get a history. Yeah, this was the immigrant who went through 20 years of struggling. Oh, but he never once felt anxious then. But it's leaking through. And I think repression, the wall of repression weakens over time and with age and can manifest years later, either in the face of acute stress or even without acute stress.
Okay, great. So, Sam, what are the three take-home messages that you want to get across and that you have in your book?
Okay, one is that the day-to-day emotional stress is not a major cause of many medical conditions. Two, there are many medical conditions whose origin we still don't understand, in whom there is a mind-body connection. Three, our repressed emotions are often more powerful emotions than the day-to-day stuff, and they persist even though we're completely unaware of them. They persist and affect us for years and decades, so that logically, the powerful emotions that are persisting for decades would be a more likely candidate to be a cause of a chronic disease. And nobody is aware of it because when we are repressing those emotions, it's as if consciously they're not there. And this is a new horizon for medicine. It doesn't exist yet in medicine thinking.
Okay. Well, this was a terrific conversation. Thanks for joining us. This is Samuel J. Mann, a professor of clinical medicine at the Weill Cornell Medical Center and the Hypertension Center at New York Presbyterian. Thanks for joining us. So my name again is Eric Hollander, and we're at the Spectrum Neuroscience and Treatment Institute and Foundation. Thanks very much.
Thank you, Eric.